nice and informative presentation. जितने भी presenters हैं उनसे एक दरख्वास्त है कि अगर आप अपनी presentation timely end करेंगे तो हमारे जो remaining जो sessions हैं हम उसको timely इसको end कर पाएंगे at the end of the day. So for this session, our second presenter is Professor of Nephrology and former Chairman and Head of Department Nephrology, Pakistan Kidney Liver Institute, Lahore. I may request Professor Hafiz Ejaz Ahmed, sir, please come on stage for your presentation.
Bismillahirrahmanirrahim. Respected Chief Guests, Honorable Panel of Chairpersons, ladies and gentlemen, I am going to talk briefly on a topic which is so common a condition but is easily ignored. Over the last decade or so, there has been abundance of literature telling us that this diagnosis is associated with very sinister implications. Once a person gets acute kidney injury, the likelihood of developing long-term complications, morbidities and mortality is very high. Acute kidney injury is a condition which is associated with retention of nitrogenous waste products like urea, creatinine and other end products, dysregulation of extracellular fluid, mostly in the form of edema and occasionally acute pulmonary edema, electrolyte imbalances like in the form of hyperkalemia, hypocalcemia and hypophosphatemia, acid-base disturbances, particularly metabolic acidosis. Acute kidney injury is a terminology which is rather new. We are more well versed with kidney dysfunction, renal impairment, or kidney failure. But it is about a couple of decades that the concept has been more unified, and in terms of literature, simplifications have been done. First time in 2004, it was a rifle criteria starting from risk, injury, failure, depending upon the level of kidney dysfunction, where the serum creatinine is increased by 25%, 50% or more than 75%. Then if the kidney function is totally lost for a month, it is called loss, and then if it is associated with dialysis initiation, it is end stage. The scope and burden of kidney disease has been increasing tremendously over the past 2 decades, and it has been found that a huge number of patients who are admitted in the hospital, they do develop acute kidney dysfunction with rise of urea and creatinine. This tells us that how it has. So if we concentrate on this group of diagrams, on the upper left side, we see that over a period of 2 to 3 decades, there has been steady increase of persons associated with acute kidney injury who are hospitalized. On the top right is in the community setting, there has been gradually increase in the acute kidney injury who are not dialysis dependent. In the lower left side, the patients who are in need of dialysis while they are admitted in the hospital, their number has also been steadily increasing. So chronic kidney injury, who is the resultant of acute kidney injury, a systematic review in 2009, the data of 13 cohort studies which has been longitudinally followed, 3,000 patients. The adjusted hazard ratio of developing chronic kidney disease after AKI was 8.8. That means there is about 9 to 10 times increase chance of developing chronic kidney disease if you develop one time an acute renal dysfunction while you are hospitalized. The adjusted hazard ratio of developing end stage kidney disease, that is severe chronic kidney disease needing dialysis, it increases by 3 times. And the adjusted risk of death is 2 times. Simply, if you are admitted in the hospital, you develop a rise of creatinine and urea, even if it is reversed, the chances of dying in the coming years become double. It's the same thing, the risk of chronic kidney disease. If you look at this, the right side, all the numbers fall on the right side, meaning that all cohorts has got increasing chronic kidney disease. This shows the likelihood of developing kidney disease needing dialysis in the long term. This is also quite high. In another study later on, the long-term risk of mortality and other adverse events in a systematic review. The mortality 8.9 versus 4.3, almost double the likelihood of death. And not only all-cause mortality, but mortality after acute coronary events and myocardial infarction is also raised twice. And incidence of AKI also many times. So that was one thing, that if you have acute kidney injury, the likelihood of CKD and death is high. The likelihood of need of dialysis later in life high. And this study shows that the likelihood of developing acute coronary events is also increased. This is a study of hospitalized patients over a period of 10 years involving 5,000 patients. There are higher incidence of acute coronary events, which is 6.1% versus 3.6%, more than 2 to 2.5 times. And there is high all-cause mortality, which is 57 versus 34, almost twice, which is in line with the previous studies I have quoted. This also shows the same thing. In this study, they have actually calculated the probability of acute coronary events later in life, taking in view various combinations. If you do not develop acute kidney injury during hospitalization, you do not have chronic kidney disease and not on dialysis, the 10-year likelihood of acute coronary event is 7%. If you have only AKI and no other conditions, it is almost double, 12 to 17%. And if you have acute kidney injury and you also need dialysis, the likelihood of developing acute coronary event is 21 to 28%, which is 3 to 4 times more. And at the lower 2 lines, you see that if you have diabetes, the likelihood increases to 31%, and if there is End State Renal Disease, it is almost certain that 1 in 2 persons will develop acute coronary events. This is another way of seeing the same thing. The probability of remaining alive over coming years. The lowermost line, you see that if you have acute kidney injury, diabetes and kidney disease, the likelihood of you being alive after 10 years is very, very little. So there is increased risk of death after de novo chronic kidney disease developing after acute kidney injury. That means if you develop AKI in the hospital and then you develop some chronic kidney disease in the long term, the risk of death is much higher. The study evaluated this de novo chronic kidney disease, 30,000 patients, which were, their mortality was compared at 90 days and later at 360 days. The median period of follow-up being about 3.5 years. The risk of death is increased about 1.5 times. The adjusted risk of developing CKD is also 1.5 times. And significant risk of chronic kidney disease overall is twice. So it means that even a resolved acute kidney injury during the hospital is associated with long-term impact in terms of kidney disease overall mortality. This is the An other important aspect, this is the 2016 study, that in addition to developing chronic kidney disease, end stage renal disease, increasing likelihood of acute coronary event, the hypertension becomes more frequent if you have acute kidney injury. 43,600 patients followed from 2008 to 11. Acute kidney injury was associated with more than twice the likelihood of developing essential hypertension in the rest of the life period. And this is proportional to the severity of kidney disease also. If the acute kidney injury is mild and goes on to having more moderate to severe thing, the likelihood of developing hypertension gradually increases. You can see from left to right, as the time goes on over the subsequent years, the likelihood of hypertension goes on increasing. This is another aspect of this. While probing this is just a couple of weeks ago, the recent article of 23, same thing has been studied, the cardiovascular outcomes after acute kidney injury. And it has been very clear that AKI single-handedly, if you look at on the right side, the middle part, the acute kidney injury unequivocally is associated with CKD and coronary events and cardiovascular effects. Similarly, another aspect is readmission and mortality. That means if you develop rise of urea and creatinine in the hospital admission, your chances of coming back to hospital is increased and mortality is also high. This is a propensity score model in which I think more than 471,000 patients studied along with the matched population, and you can see an eye-opening results. Rehospitalization from any cause is increased 1.6 times. Development of end-stage renal disease 6 times. Heart failure about 3 times. Hospitalization with sepsis 2.5 times. Pneumonia 1.5 times. New myocardial infarction 1.5 times. Volume depletion. And all these impacts are equal if you study them at 90 days or 365 days. The impact remains the same. This is the same thing whether you have chronic kidney disease or not, the chances of sinister events goes on increasing. So in summary, the acute kidney injury during a hospitalization puts you at increased risk of CKD, an increased risk of developing end-stage renal disease. There is increased risk of dying early. There is increased risk of rehospitalization, and there is increased risk of new coronary events. This was an initiative by International Society of Nephrology more than 10 years ago. They wanted to prevent this acute kidney injury so that the incidence becomes zero by the year 2025. Almost more than 8 years have already gone and many initiatives have been taken, including global survey, and then they actually selected 4 or 5 areas in the world, and networks were developed and more support was performed by the experts, and preventing the death was planned. We don't know what is the impact of that initiative, but it has actually highlighted the sinister impact of this condition. So we have a challenge ahead, all the healthcare professionals, whether we are general practitioners, medical specialists or experts or nephrologists, the burden of acute kidney injury is increasing. We all know that it is associated with adverse outcomes. Many factors of acute kidney injury are known and identifiable, and in many cases AKI is preventable. So we would recommend that AKI should become the part of public health policy priority, keeping in view the severe and sinister impact. So in meeting the challenges, I would suggest that we should early identify and have a cognizance of this condition. Our doctors should be trained with the new definition of acute kidney injury and KDIGO classification. We should treat those conditions promptly which lead to this, like sepsis, shock, ischemic events, dehydration, and we should be very active in treating the comorbidities which can lead to this, like diabetes, hypertension, renal calculi, and very important is avoiding and minimizing the use of nephrotoxic medicines, many NSAIDs, antibiotics, which we become careless at many times while we are dealing with our patient. Thanks very much.